questions you want us to?
If you want to sit here and answer questions, that's fine. I can put a microphone
I
right
think
here.
that would be good.
Would that be okay? Let's do that.
Because John, I just stand here and I need my slides to work from. And
Thank you guys for coming. So we have two guest speakers here today to talk to us about the Affordable Care Act. Many of you probably know Carolyn Engelhardt. She's the director of the Health Policy Program in the Department of Public Health Sciences at UVA, and she's written extensively about the Affordable Care Act. And then we have Marty Reiser, who also happens to be the brother of Robert Reiser, one of our EM faculty. And more importantly, he's the legislative counsel for the House Majority Whip and works on, amongst other things, healthcare. So I'm not going to spend a lot of time talking about their accomplishments. I just want them to get started and make good use of our time.
okay. Good morning, everybody. It's great seeing those of you I know, and I know this is a topic that's timely and somewhat, I don't know, controversial, volatile. So Marty and I each have about 4 or 5 slides. We're going to each take about 15 minutes or so that we have lots of time for discussion. So I'm going to lead off. Most of you I know what the Affordable Care Act is, but I thought it would be helpful just to walk through the components of it. So as we then talk about its future, we'll be able to refer back to its pieces. And while the 2,000-page legislation actually addressed both access cost and quality, most people think of it as expanding coverage, and I would argue that that was its primary goal initially. So there were, as you know, before the ACA was passed in 2010, we had chronically in this country 40 million people without health insurance, the only developed nation that did not have some sort of mechanism for universal coverage. And so the ACA, although imperfect, tried to address that by building on the existing system that we had. And it did so in a couple of ways. The first was by developing these things called exchanges, which the administration later renamed marketplace because exchange didn't translate well into Spanish. So it really confused people. I will probably refer to it as exchanges. That's how I learned it. But they often, you'll read about it now as the marketplace. But they set up these exchanges either at the federal level or at the state level. The statute expected that states would set up their own because states typically regulate insurance. But the statute said that if states did not, then it would, they would go into the federal exchange. And on these exchanges, there would be a minimum essential benefit package that each health insurance company would have to offer. No longer could consumers be denied coverage because of pre-existing condition. Women could no longer be charged more than men. Older Americans could be charged only 3 times more than younger Americans, which is less than it was before. And there were no more lifetime limits on using certain medical services. So it was an attempt to bring in people who heretofore had been in the individual group or who had been uninsured, and they would be, if they were under 400% of the federal poverty level, which was about $16,000 for, which was about $46,000 for one person, they would receive a subsidy. Clearly, if they were at 100% of the federal poverty level, they get a very large subsidy to help buy insurance, and if they were at 400%, they'd get a lesser subsidy. And that was the structure of that. The second piece, or the second leg of our coverage stool, if you will, was to expand the Medicaid program. Now, all of you have Medicaid patients, and you know that traditional Medicaid is what we call a categorical program, and that means that it only covers certain categories of people: poor children, poor pregnant women, disabled, frail, elderly. That's about it. Many of my students are surprised to know that if you are a homeless, childless adult, in many states, including Virginia, you are ineligible for Medicaid unless you're declared disabled. So the idea under the ACA was that there would be an income threshold of 138% of the federal poverty level, which was about $16,000 per person, and that regardless of your category or your status, you would be eligible for Medicaid. Now, we all know that immediately that was challenged in the courts, and 2 years later, the Supreme Court declared that the federal government could not compel states to participate, but it could be optional, and I'll talk more about that in a minute. The third piece of it, if you will, has to do with employers. The law required employers with more than 50 employees to provide what they called qualified health coverage, which meant that they had to offer health insurance that had these essential benefits and where the employer paid a certain percentage of the premium, or else they would pay a penalty. One aspect of the ACA that everybody liked a lot was the attribute where young adults could stay on their parents' plan up to the age of 26. Since 2010, when the law passed, this was one piece of the law that actually went into effect pretty soon after the law was passed. There have been about 7 million young adults who have remained off and on their parents' health insurance plan. There's usually 2 to 3 million at any one time. There's been about 7 million altogether, and that has been a very popular part of the legislation. And then finally, for those who make too much money to get a subsidy, there were in the individual market off the exchange, was also regulated such that the same rules applied as far as not being able to discriminate based on medical history or gender and those sorts of things. So that's really the structure of the ACA as far as to expand its coverage, and it was all sort of tied together by this individual mandate that required everyone to purchase health insurance. There are some waivers, but that's really getting way down into the weeds. This was probably the least popular aspect of the Affordable Care Act. Some things in our collective DNA as Americans that we feel that a government should just not tell us that we have to do something, and this received a lot of bad press. Okay, so where are we today? The exchanges and the Medicaid expansion rolled out January 1, 2014, so we have a little bit of experience. What do we know? Well, we know that the majority of states did not set up their own state exchanges. Most of them defaulted to the federal exchange. You can see here only 12 states and the District of Columbia set up their own exchanges. The first year, 8 million signed up, but then there was some fallout for a variety of reasons. So you have a net enrollment of a little more than 6 million in year 2, a little more than 9 million, and so far in year 3, because enrollment ended the end of January, we have about a net of about 11 million people. This is not additive. This is in total. So it's not like 6 plus 9 plus 11. It's like 11. Oh, shoot. Sorry about this, guys. Okay, got it. All right, so the Medicaid expansion. Medicaid expansion has been embraced by 31 states plus the District of Columbia. You can see here 15 million new signups under the Medicaid expansion. Obviously, it's expanded much more in those states that have decided to expand. 1 in 5 Americans now are covered by Medicaid, which is pretty significant. We think of Medicare as being a big federal program, but Medicaid actually has many more people in it than Medicare. Of those states, like Virginia, who did not sign up for the Medicaid expansion, there is a perverse consequence of the law was never intended, called the coverage gap, which means that we actually have people who are too poor to go to the exchange. The exchange offers subsidies starting at 100% of the federal poverty level. So if you're a mom with 2 kids or a dad with 2 kids and you make $17,000 a year, you make less than 100% of the federal poverty level for a family of 3, and you are ineligible to go to the exchange and get a subsidy, and you essentially fall into this gap where your children are eligible for Medicaid, but you as an adult are not, so you remain uninsured, where your neighbor who might make $6,000 more than you could go to the exchange and essentially get a free ride. There are 3 million nationwide in that coverage gap. In Virginia, there's about 300,000. Has it worked? Well, if you look at number of uninsured, most policy experts say that 20 million people are now insured that were not insured before, but there's still almost 30 million who remain uninsured. And the exchanges have not performed nearly as well as the Congressional Budget Office predicted. According to their predictions when the law passed, by this year, they thought there'd be over 20 million people on the exchanges. You can see now we have maybe 11 million, and that causes some problems, which might suggest that those who sign up or those who need insurance, which is a case for what we call adverse selection, which leads to higher premiums, which I'm sure you've been reading about. And it also means that the majority of the newly insured are insured through Medicaid and not through the exchanges, which certainly I don't think was the law's intent. Okay, what have we learned? So we've learned that getting to universal coverage is going to take a long time. Unlike other developed countries, we don't have mandatory participation. We don't just take it out of people's taxes. We have a voluntary program where people have to pay a penalty, and many people make the choice not to because they feel that the marginal cost is greater than the marginal benefit. We know that safety net providers like UVA and states that have not expanded their Medicaid program are still seeing large numbers of uncompensated care of indigent patients. Sorry about my shorthand, but that little stuff there means that in Medicaid expansion states, they've seen a $6 billion reduction in uncompensated care costs or spending, and in non-Medicaid expansion states, it's not changed. We know that enrollment on the exchange is strongly linked to the subsidy and to income. Over 80% of those who signed up through the exchange receive a subsidy, receive actually quite a healthy subsidy. $37 billion will be spent this year on those subsidies. Only 16% of people who had between 300 and 400% of the federal poverty level signed up. That's because again, the average non-subsidy plan under the ACA is about $400 a month. And if you're at 300 or 400% of the federal poverty level, that's a pretty big chunk out of your monthly paycheck. So we've got some problems. Coverage alone, expansion, does not guarantee public opinion or good public opinion. Liberals see the ACA as a success. They see the coverage expansion as good. I would say conservatives see it more as a redistribution technique on the part of the government giving hard-earned money to people who are increasingly dependent on government programs. The ACA clearly moves us towards a more social insurance model as opposed to an actuarial insurance model where you're based on medical risk. What does that mean? It means that there are winners and losers. The healthy subsidize the well, the young subsidize the old. And then this community rating is used to spread the risk and the cost, which means that young, healthy 35-year-olds who were able to get pretty cheap plans before now have to buy very comprehensive plans that are much more expensive. On the other side, people my age who perhaps didn't have employer-sponsored insurance and had to go to the market to buy health insurance but were charged 7 times more than a 25-year-old, we benefit. So it really depends on where you sit. This is a chart that looks, it's from Real Clear Politics, where they do a compendium of all polls, and it looks at the approval of the ACA, the health plan, over time. And you will see the red line is oppose, and the black line is approve. And you will see, since its passage, the majority of those responding to polls have said that they don't like it. Even though when you survey Americans and ask them if they like pieces of it, do they like having their kids stay on their insurance plan? Do they like not having medical history count against them? People like that, but they don't like the thought of it. They don't like Obamacare. So the next debate, I think this is my last slide, the next debate in healthcare is really going to be about affordability. This graph or chart shows you the rise in deductibles, and this is not just what the deductibles are, but what people pay out of pocket. And you can see that what people are paying out of pocket for health care far exceeds the growth in the deductibles, far exceeds the growth in their wages, which means, of course, that their wages don't go as far. There are opportunity costs. They can't buy things they would have before because more of their paycheck is being eaten up by healthcare spending. 43 Americans, many who are insured, have trouble paying their medical bills. So clearly we have a ways to go. So the next debate will be about the adequacy of health coverage, how much cost sharing is too much, and what we need to do about it. Oh, shoot. I will just say, though, with 90% of Americans covered some way through some sort of health coverage, even if Donald Trump is elected and the House stays Republican and the Senate stays Republican, it will be very difficult to repeal this law because it has really grown roots into our society. That doesn't mean that things can't happen, but I think politically it would be very difficult to start over at this point. Okay, that's all for me, and then turn it over to Marty, and then we'll be able to answer some questions. Thank you.
Good morning, everyone. Just a little background on me. My name's Marty Reiser. I am Dr. Reiser's brother. I come from a slightly different perspective on some of the issues than my brother, so that will be fun today. I've been working on healthcare policy for a little over 25 years in Washington. Started my first big project that I work on was opposing Hillary Care back in the 90s as a congressional staffer, and then later opposed and worked against the passage of the ACA. And since coming back to the Ways and Means Committee in the Majority Whip's office, I've spent the last 5.5 years as part of that effort to try and repeal the law. And I've been on the floor of the House for most of those 67 votes where we tried to repeal all or parts of the law. The only reason to say that is to give you some background of where I am coming from. I do think the ACA was the wrong solution at the wrong time, done in the wrong way. But we are 6.5 years later. I'm not going to go through all the things that I thought was wrong with the law, but try and talk about where I think we are headed and go at it that way. I would tend to agree that even if Donald Trump were to win the election, it would be very difficult to repeal and replace the law in all of its parts. It's been 6.5 years, and there are a lot of roots, and it has taken hold, and there's been a lot of transformation in each individual market, including the employers, the private sector, Medicare has gone through several changes, Medicaid, so I think it would be very, very difficult, but that doesn't mean we won't try to do it. But that's only if Donald Trump were to win the election. So for the rest of this discussion, until we get to questions, let's just assume for the moment that Hillary Clinton does win the presidency, which looks somewhat likely. Medicare, the way I would look at the ACA moving forward is the ACA is not one thing. And we just went through some very good statistics and a structure of the law, and I want to do the same thing from a slightly different perspective. Each of the four areas, major areas of the ACA, Medicaid expansion, the private exchanges, the employer market, and Medicare, need to be changed. And I wouldn't say that that's necessarily a bad thing. The ACA is now 6.5 years old, and it's a major law, and it transformed health care. There's nothing inherently wrong with the two sides coming together to try and fix different pieces. That's normally in the normal political process in the history of our country on major legislation, and after 6.5 years, there are adjustments that need to be made. And I think there's a possibility of being able to do that even in this difficult political environment. As a note of optimism, I would say the last 2 years have actually been a very productive bipartisan session on health care. We have made significant achievements in the last 2 years on a very bipartisan basis. I would mention the SDR, or the doc fix. It took 18 years for us to come up with a solution of how to finally figure out how to pay doctors without these big fiscal cliffs. We got that done in the House with 393 votes, and it got passed in the Senate with over 90 votes. As part of that, we expanded community health center funding, and we reauthorized CHIP, which was a Hillary Clinton and Orrin Hatch project in the late 90s. So that got done. Earlier this year, right before we left for our 7-week recess, we sent to the president, and he signed the opioid legislation. Again, another bipartisan bill passed with over 400 votes in the House and over 90 in the Senate. We have passed mental health reform. We have passed 21st century cures both on major bipartisan basis. 21st Century Cures is a bill that will expand funding for rare disease research, including Alzheimer's and Parkinson's at NIH, open up the FDA process, and open up some of the grant making at NIH. The administration and the House Republicans are spending a fair amount of time this month discussing a deal which we will advance the 21st Century Cures legislation and add in the cancer moonshot. And I expect that we will probably come to an agreement and get that bill signed in September. We will do the same on mental health legislation. And we will, despite the fact that we are currently going through a fairly pointless and frustrating political debate over Zika funding, I'm very confident that we'll get Zika done in September as well. So we do have an ability to do bipartisan health legislation. The ACA obviously has not been particularly bipartisan, and it's been a pretty bitter fight. But we're about to have another election, and we're about to have somebody not named Obama in the White House defending Obamacare. So Hillary Clinton is already calling for changes to the ACA, including the repeal of the Cadillac tax, which is on the employer side. So I do think we have an opportunity to step by step make changes to the ACA that I do strongly believe are needed. First, on the Medicaid expansion, I think you would have to argue, no matter where you're coming from, that the Medicaid expansion is probably the most successful part of the ACA. You saw the numbers on the number of people that it expanded coverage for. But it wasn't free. And Medicaid was a program in desperate need of reform before the Medicaid expansion. The states are currently facing looming fiscal crises, including the state of Virginia, that need to be addressed, and they can't issue debt to do it the way the federal government can. Currently, states have depending on interest rates, and your assumed rate of return, states currently are looking at a $1 to $3 trillion underfunding of their pension systems. And these pension systems are about to hit the baby boom generation wave, and the costs are going to go up massively. We worked this year on the legislation to solve the fiscal crisis in Puerto Rico, and that took we did that on a bipartisan basis. That took a very long time, mostly because we were afraid of making it the model for how we are going to deal with the bankruptcies of states, which both sides agree is inevitably coming. Illinois is within years of filing for bankruptcy, and California is not far behind. The Medicaid expansion was intended to induce the states to expand because the federal government would pick up all of the costs of the newly eligible population until 2019, and at which point the federal government would pick up 90% and states would pay 10%, which is a much higher federal matching rate than the existing Medicaid population. And that all happened. But one of the most interesting things about the Medicaid expansion, which people really didn't anticipate no matter which side of the aisle you were on, was what they call the woodwork effect. Particularly in the states that expanded, people who are already eligible for Medicaid signed up. That's probably because of the individual mandate and the fact that the states that expanded did a fair amount of recruitment and education about people's eligibility. But a lot of the coverage expansion has actually come from people who are already eligible for Medicaid prior to the ACA. And that's a good thing. But it's not free to the states. Those matching rates are at pre-ACA levels, and so it's actually increased costs fairly significantly for the states that have expanded. It may or may not be a good thing, and obviously it's a good thing to have health insurance, but states have to make decisions between funding their pensions, building roads and bridges, and putting money into schools, and those are choices that have to be made. The other thing I would argue about the Medicaid expansion is a fairly significant part of the population that became newly eligible for Medicaid, just because of the way we did our income, were young, healthy males who, a large proportion of whom have been in prison. And I don't say that to disparage in any way those people. They had been in prison, they paid their time, and in my personal perspective, probably a lot of them never should have been in prison for the first place. And hopefully we'll do criminal justice reform this fall as well. But the reason I raise that is if you're going to throw federal resources at that population, and we should, probably providing health insurance for them is not the right place to put those resources. If they need any health resources, they probably need drug treatment and mental health, not traditional Medicaid insurance. So to me, it was a misallocation of resources in the way they went about doing it. And because the states are facing these looming fiscal crises, and because the 90-10 matching rate will kick in, I do think we will have to look at legislation to change the way we're doing the Medicaid expansion. I think it will be very difficult because the two parties come from very different perspectives on the Medicaid stuff, but changes will have to be made. On the public exchanges, this is probably in the public's mind the popular view of what Obamacare is, and it's what drives the unpopularity in the polls that you just saw. It's actually the smallest part of the market that ACA covers. It's only about 20 million people in the small and individual group market versus 77 million on Medicaid, 155 million on employer-sponsored insurance, and I don't have the figure for Medicare, but it's much larger than the 20 million. So this is where the failure of healthcare.gov was. This is where the individual mandate really hits home. And most importantly, this is where Obamacare is not working and will not work. The top 5 insurance companies in America have recently announced their earnings, and they all lost money on their exchange businesses. The way the ACA is structured, it mandates a very expensive series of benefits It does the community rating so that the young are supposed to subsidize the old, and they're not getting the right mix of people signing up, and they're not going to, in my opinion. And increasingly, that's the opinion of insurers as well, is because they're pulling out of markets and driving less competition when the whole purpose of the exchanges or marketplaces was to increase competition. The insurance companies are losing money despite the fact that in the first several years there are billions of dollars of subsidies for the insurance companies from the federal government, risk corridors and reinsurance being the two really big ones. Those programs end at the end of this year. They were 3-year programs to help stabilize the market, and the insurers are still losing money despite that. Their Blue Cross Blue Shield, who is, by the way, actually making money in the exchanges, but the reason they're making money in exchanges, they get the bulk of the transitional reinsurance money. There is a $5 billion payment, which the law very specifically says this $5 billion that's collected from employers on their health insurance plans is to be returned to the federal treasury and not used for transitional reinsurance. The whole program was $25 billion. This $5 billion chunk was to go to the treasury. The Obama administration has announced that they're going to give that $5 billion to Blue Cross and Blue Shield predominantly. The Government Accounting Office has issued a letter, legal opinion, saying this is completely illegal. I fully expect that we're going to lose that fight, and the Obama administration will give the money to Blue Cross Blue Shield this year. But without that illegal payment, Blue Cross would lose $5 billion, and they're going to lose that payment next year anyways because the program ends. So the exchanges are where we're really going to need to make significant changes to the ACA. It's also probably the most difficult place because it is a complicated market. I've spent the last 6 months, along with 5 or 6 of my colleagues, drafting the Republican Replace Plan. We call it the Repeal and Replace Plan, but it's our Replace Plan for Obamacare. And we have met with, we had a task force of 45 members, and we actually sat down for an hour and met with each one of these members of Congress individually to talk about what they want to do in the healthcare space. These aren't the most technical of discussions with these members, but you do learn an incredible amount because members of Congress do have a good understanding of what people want. That's kind of their job description. And one thing that in one of those sessions a congressman said to us, which really kind of crystallized to me the dilemma both Democrats and Republicans are facing, is we can't deliver what the American public wants on health care. Because what the American public wants is they want it perfect, they want it now, and they want it free. And that is pretty true, pretty accurate description of what they want. And the exchanges are not free, they're not perfect, and they're not now. And our solution, I think, to fixing the exchanges is certainly not going to be free, and it's not going to be perfect, and it's probably not going to be now either. What we would do is get rid of a lot of the insurance mandates. The ACA mandates a very generous package of benefits and says if you're going to have health insurance, you have to buy all these benefits. We would get rid of virtually all of those at the federal level and return it back to the states to regulate insurance. We would then, how we would handle pre-existing conditions is very different than the ACA. And I think it's probably going to be one of the most politically challenging parts of our plan. If you do look, when you do look at the individual parts of the ACA, the most popular part is the banning of pre-existing conditions coverage. We would still ban pre-existing coverage for those who have coverage, and if they change jobs or change insurance plans. So we would get rid of the individual mandate, but the incentive for people to have health insurance would be you cannot be medically underwritten if you already have health insurance. It would dramatically lower premiums, but I think you could probably figure out some of the criticisms of that particular approach. But it would achieve lower premiums, but we would also probably lose people who have with coverage fairly substantially. So our plan has flaws in it as well. I personally think it's much better because it lowers costs, which is what we focus on rather than expanding coverage. But this is where we're going to have to change the exchanges, and we're going to have to figure out how to get that done. On the employer market, I think that's going to be a lot easier. There are already over 300 co-sponsors divided equally between Democrats and Republicans that want to repeal the so-called Cadillac tax, which is a tax on high-cost health care plans. How you define high cost is, depends on your perspective, but the ACA defines it by a dollar threshold. It's proven very, very unpopular with unions and businesses alike. So there's been this marrying of Republicans and Democrats that want to get rid of that tax. I think that will happen fairly early in a Clinton presidency, and it provides the legislative vehicle that there's going to be changes to the ACA, and we'll try and add on from that point on. I think Republicans will want to, as part of that, repeal the employer mandate. Prior to the ACA, there were a lot of problems in health care, but the one place that there wasn't really any problem worth fixing anyways was in the employer market. 155 million people get their insurance through employers. They like it, and it was voluntary, and it had absolutely no mandates on it, or not absolutely, but very, very few federal mandates. And that's why the system worked. Employers continued to change their program, make it more and more, as the time went on, what their employees wanted, and it fit their particular labor force. The ACA did not make substantial changes to it, but it made some, including moving it from a voluntary system to a mandatory system. Republicans don't like that. Businesses don't like that. Because it makes it much more difficult to innovate. It hurts low-income workers from our perspective because the cost of hiring somebody goes up, and that hits the lowest income thresholds the hardest. So we don't like it. So I think we'll probably, the possibility that we will get rid of the employer mandate and the Cadillac tax is a place where we can make progress on changes of the ACA pretty early in a Clinton presidency. Finally, on Medicare. The ACA made a lot of changes to Medicare, and it's one of the reasons I truly believe it was a mistake. As I said, it was the wrong solution at the wrong time and done in the wrong way. We are facing a massive demographic change in this country, and we have not figured out how to pay for Medicare. Oh, I forgot. This was our Better Way Plan slide. Sorry about that. Over the next several years, up until 2089, we are about to see a massive increase in federal health care spending, driven in large part by the aging of our population. Medicare will drive a lot of it. Medicaid will as well, because Medicaid actually pays for long-term care, and as the Alzheimer's crisis continues to expand, that's going to become very, very expensive for both states and federal government. But Medicare is about to increase substantially. The ACA cut $750 billion out of Medicare. Now, clearly, we're going to have to make changes to the Medicare program. But to use that money to spend it on other people's insurance really doesn't solve any problem. We haven't reduced the federal obligation to overall health care. We've just taken money from one pot and put it in another. And both Democrats and Republicans alike have made promises that we cannot keep over the next 30 years. By 2040, our national debt will be estimated under current law to be 140% of GDP. That's not sustainable, even for a country like ours. Spain and Greece's debt at the height of their fiscal crises, which almost brought down the EU, their debt ratio was 110%. There's absolutely no way in the world that the United States, the reserve currency for the global economy, can sustain a national debt that approaches 140%. We're currently at around 85%. And it's all being driven by healthcare spending. So the politics of the next 15 years are going to be very difficult, very bitter, because we're going to have to figure out, on somehow on a bipartisan basis of how we reduce our federal commitment to overall health care, which is essentially why I really think the ACA was a mistake. We should have started doing that a long time ago, and we shouldn't have started this long, difficult process by expanding the federal commitment to health care by over $1 trillion, which is what the ACA did. So with that, I will stop there and be happy to answer any questions that people may have. So.
Okay, your turn. We've left you speechless. Yeah.
In some of the campaign talk on the left, there's been renewed talk of a public option. Do you think that is a possibility for happening, and how do you think that would affect the ACA?
So for those of you who may not know what a public option is, when the ACA was being drafted, you know, from your civics class, you have a bill on the House side, you have a bill on the Senate side, they come to conference. We won't talk about how the ACA never really did that, but on the House version, there was this public option, so that on these exchanges, there would be a government program, a government plan that would compete with private insurance. That would be one of the options. It was it was popular with liberals and for single-payer people, but it was very unpopular with a lot of the stakeholders. Physicians and hospitals were afraid it would drive down reimbursements. Think of Medicare, Medicaid reimbursements versus private insurance reimbursements. And the insurance companies felt that it would just be a very slippery slope to single-payer. I think that it is one way to, right now we've got several states, as Marty mentioned, where the insurance companies have exited and they have no, Alaska is in big trouble. They have no carriers or one carrier on the exchange. In those rural areas where there are, at big states where there is not a lot of competition, it may be that that public option would be a viable alternative for people. It would be a program they could sign up for. But politically, I think it's going to be a hard fight, except for the Bernie Sanders folks who are holding out.
Yeah, I would agree with that. I mean, I think the challenge, the way I look at it is, there's nobody in healthcare that has got a more difficult path in the future than insurance companies. The way the ACA is designed. On the left, the Democrats would like to put in a public option. They will not get rid of any of the mandates. And on the right, we will not subsidize the insurance companies. The insurance companies will fight very, very hard against the public option. I would expect it would be very, very difficult in isolation to put in place a public option. But again, as part of this overall deal, if there is going to be changes to the ACA, if that's something that the Democrats insist on having, we're going to have to get something that we insist on having as part of it. So I wouldn't completely rule it out, but it's in isolation. I wouldn't give it much of a chance.
I'm sorry, I couldn't hear you.
Marty mentioned that there would be a change in the pre-existing condition coverage possibly, so could you clarify exactly what?
Sure. Could I clarify how the Republican Better Way would handle pre-existing conditions? So prior to the ACA, insurance companies were allowed to medically underwrite people that applied for insurance on the individual and small group markets. The ACA banned that practice and said that they cannot medically underwrite. You must take all comers, and you must not charge them based on their health status. And as a result of that, combined with all of the benefit mandates, it's made health insurance much more expensive than it used to be on the individual and small group market. So what the Republican plan would do, we would also say that no insurance company could deny coverage to anyone based on their medical status, period. However, they could charge higher prices based on your medical status if you don't currently have health insurance. So if you are currently one of those 10% of Americans that aren't insured and you have a difficult disease, the insurance company could charge you more for your health insurance coverage. The way we would then take care of those particular people are federal funding of high-risk pools, so that the risk pool money would then go to that insurance company in order to subsidize that company to lower the premium for that high-risk individual. Other than that, if you have health insurance, you cannot be medically underwritten, so they would not be able to charge you higher prices based on your medical status. So if you're working for Google and you decide to go start your own business, and so you have to go into the individual market, if you had health insurance at Google, when you go to buy health insurance on the individual market, they couldn't charge you more based on your health insurance, on your health status.
So basically, what would happen is that it would segment the risk pool. You would pull out the high utilizers in order to keep the premium stable for those who don't use as much health care. High-risk pools are not new. Many states had them before the ACA, and most health policy experts, I think, feel they didn't work very well. The premiums were usually 200% of the average premium in the market. Depending on what state you were in, you had more or less subsidies. They tend to be grossly underfunded, and people end up remaining, people who have pre-existing conditions and chronic illnesses tend to be uninsured. The other piece of that is that with removing the pre-existing condition exclusion and the guaranteed issue, except for continuous coverage, what you will end up with are millions more people without insurance who will show up in the ED here expecting to be treated, and unless and until we do something about the disproportionate share funds that compensate safety net hospitals for caring for those folks, we're just gonna be in this same old problem that we've been in before the ACA. So most countries get around this by having everyone in the risk pool, by making everybody have insurance, by taking it out of their taxes. That's just not who we are here. And as Marty mentioned, we don't want to screw up employer-sponsored insurance because it's working really well, even though it deprives, I know this is a very loaded language, the federal treasury of $300 billion a year in foregone taxes because of the tax preference everybody gets with employer-sponsored insurance. So know that while it would reduce the premium, it might attract younger people to buy insurance. For those people who go without 60 days or whatever it is with continuous coverage, they will end up being exactly like the indigent patients you've had all before the ACA. And for the high utilizers who are carved out and put into high-risk pools, there will be a significant portion of them that will not be able to afford insurance unless there are hefty subsidies.
Well, I would first say I agree with all of that, believe it or not, except for one piece, which is the previous experience with state high-risk pools. I actually agree that that was the previous experience with state-based high-risk pools. The Republican plan would federally fund these, and we would federally fund them at a very, very high level. We take a lot of money out of Medicaid, which may or may not, be a good thing, but we substantially fund high-risk pools at about $25 billion a year, and the previous experience with the state risk ones is they just didn't have enough money, and as currently drafted, our plan takes care of that part of the problem.
Yeah, up there.
So, Marty, I appreciate your point about young, healthy prisoners not necessarily needing Medicaid. Would Republicans feel that universal coverage is a priority that we should have in our country? And what is the government's role in that?
Yep. So, yeah, the question is, what is the Republicans' perspective on universal coverage, and is that something we should be working towards, and how high of a priority is it for Republicans? I think, to be frank, I think we believe that there absolutely is a federal and state role for health care, but health insurance in and of itself is not the goal. It's trying to figure out the best way to take care of people. And we certainly don't view it in terms of a right. We do view it as a public good, and more people should be insured. But that has to be stacked up against other priorities, which includes the fact that we have promised people health insurance, specifically on Medicaid and Medicare, which we have not been willing to raise enough resources to pay for in the future. So making empty promises that everyone should have health insurance and we'll take care of it is, I guess the way I would put it is, it's somewhat empty promise until we figure out how we're going to deal with the promises that we've already made. So.
Let me just add that I think whenever we get into these discussions, you know, it sort of becomes sort of dire. But I do think there's kind of a middle way that might be